Oh. Oh. Hello, Marcos.
Hi, John. How are you?
Good, how are you?
Nice to meet you again. Hope today gonna have a great discussion and meeting.
Good. I think
Yes.
you're going to get a good crowd.
Yes. Yes.
How are you doing?
Hi,
Good.
Iris. And you?
We just. Hi. Anybody else want to check in?
Abre sua câmera, Iris.
Well, now you can admit people. You see, I let you be
Yeah.
co-host, right?
Yes.
So you can admit people, Marcos.
Next
If there's-
time, the final.
If there's somebody else, yeah, for somebody else, let me know.
Fabio, Zener.
Okay, you can admit them. Go ahead and admit them.
We are a bit ahead of time, no?
Yeah, here in Brazil is lacking 8 minutes. Where is the
Okay.
Professor Goel?
Okay. Can you admit people? Are you seeing how you can admit them, Marcos?
Can what?
You can admit people. You're a co-host. You can admit
Yes.
people.
Yeah.
Okay. So keep an eye on that if you want to admit somebody.
Mhm. Yeah.
Sometimes I miss it and I don't.
No problem.
Yeah, we'll talk later about that other conference on epilepsy.
Okay, I'll let you know.
You know,
It will be good.
you know, I'm starting a group in Spanish on epilepsy. Let me,
Spanish?
yeah, because a lot of patients don't have good backup for information. Let me show you. And people say that English has a lot of web sites for support. You know what I mean?
Yeah,
You
it's
know,
a challenging disease, epilepsy, refractory ones.
yeah, patients should become educated about it.
Mm,
You know, it's in Spanish because there's not much in Spanish.
mhm. Spanish is a challenge for Brazilians to speak correct.
We could do
Not
it in
that easy.
We can do it in Portuguese too,
Mm,
if the demand warranted it. Warranted. We'll see. We'll see. The thing I'm working on now is changing the concept of advertising, so that companies can advertise your webcast, can pay for it. Do you know what I mean, Marcos?
yes, yes, I know.
Yeah, they support education. They did before. They helped, you know, televise. They would host conferences, but now I don't think we're going to have as many conferences as before. A lot of digital. So I'm giving them a way to get involved with online education, a model of it, advertising, because technology has improved advertising. It's improved it. It's going to change it.
Mm, yes, they change a lot, technologies and so on.
People will say, I can afford to be crazy and try things like that because I'm not WFNS or Stanford or anybody else who have to have meetings and approvals and no. If I have an idea, well, let's try it.
Yes, yes, not that bad because
Yeah,
life is for
I
us.
think I might.
Easy.
Well, the thing I'm working with it like I'm working with Benjamin, with the gentleman from India that has a company. And we just had a webcast with China. And after he stayed on the webcast and we tried to interact, but vendors have to learn how to use Zoom. He came with a bad connection, which shows that he's not very experienced.
Mhm.
Just like doctors,
Where is
when they
he
come,
from? India?
he's from India. India. He has. Let me show you. Let me show you one of his webcasts here. I just did it. Chinese, I'll show you. Okay. Uh,
Professor Goel is in here, please.
is he here?
Yeah,
Okay, you can let him in.
wait a moment.
Yeah.
Okay.
Okay, can you see the screen, Marcos?
One moment. Yes, I can see.
Okay, this is the one we just did from China, okay? And you can see at the bottom of the screen, the banner. You see the banner, San Mas? You see okay, now the thing is, Marcos, when people click on the QR, the person advertising can put any link he wants there. So he can open up another Zoom, he can open up a live discussion of the product. He can be given an address to make an appointment with the vendor. In other words, the vendor has control of that link. So it lets the vendor kind of participate. He could put a link on whatever they're talking about the tumor or whatever. So the vendor gets a chance to participate more or less in the conference and what he shows to them after the webcast. Of course, it's after the webcast. It's not before. It doesn't interrupt. Anyways, that's what it is. Okay, Atul, how you doing? The king is here.
Hi.
We all arise.
My dear John, my dear Marcos, I can see you. How are you?
I'm fine, Professor, and I have a great notice for you that today is the Brazilian Neurosurgical Day here in Brazil.
Very good.
So
very
it's
The country
really
stops.
happy day for us.
The country stops, Atul.
good. Yeah.
Now, lots of work. Okay, here I want, can we start now, John?
Yeah, you ready to start? Okay, I'll count down. I'll introduce you, okay? And then you take it from there.
Okay.
Okay, Marcos? And you introduce
Yes.
Atul, and then we go from there,
Yes.
okay? Here we go.
Okay.
10, 9, 8, 7, 6, 5, 4. Hold on. Let me make sure I've got it on YouTube. I'm gonna make sure about that. Sometimes I forget. No, it's on. It's on. It's on. Okay. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning. This is Dr. John Bennett broadcasting from sunny Miami. We're not starting soon. We're starting now. We have the honor of having the king. We call him a king because we admire him, his dedication throughout the years of writing articles, publicizing. He's probably the most published author in neurosurgery. And I'll let one of his big fans, Marcos, introduce him. Okay, Marcos, it's all yours.
Yeah, thank you, everyone from Neurosurgical TV. I'm Marcos Wagner from Brazil, Northeast Brazil, Campina Grande. And I'm really happy today to be here with you. And today is our National Brazilian Neurosurgical Day. So it's a celebration. Now, we're happy to have the king, Professor Atul Goel from India, Mumbai, which I visited his department, saw many surgeries, was a really great experience. And together with Professor Atul Goel, we have Dr. Fábio Santana from Belo Horizonte, from Hospital Odilon Berens, Socorro, outros hospitais todos. Meu chefe, he was my boss. And it's really a pleasure to have him with us. And Dr. Ivens Fernandes from Campinas, Hospital Centro Médico de Campinas e Hospital Municipal Mário Gatti. Teremos também o professor Dr. Denis Zonadoni, de São Luís do Maranhão, do Hospital Universitário lá, where he has a great research on craniocervical junction disease and pathologies. So it's a great pleasure. And Professor, you can begin. And it's the third series that we had. So the next one will be the fourth. And Dr. Evans wants to invite you to give one lecture about his papers. And if you allow, he will be ready for that. And Dr. Fabio, today we will also have some cases. So today is a really great day for us to commemorate. Thank you.
You think I should begin, Marcos?
Sure.
Yes.
Okay, so first of all, I send you my best greetings on the Neurosurgeons Day of Brazil. And I'm sure Brazilian neurosurgeons will be very happy. I can see some happy faces on the screen. And I see some very senior neurosurgeons on the screen. So it is my great pleasure and absolute honor to present, which I believe complete, not little bit, complete revolution in spine surgery. And more I talk about it, more and more time passes, more and more number of cases I'm doing. I'm absolutely convinced in what I'm saying. And I want all the young and senior neurosurgeons to listen to what I'm saying, to think about it. Naturally, there will be several questions that will emerge in all your minds, which is absolutely natural and has to be there. And I'll be available to answer all your questions. But I must tell you that whatever I speak is all published. And whatever I have published is in very top neurosurgical journal. So just remember that. So I want to introduce to you an absolutely new concept of spine surgery, a new version of spine surgery. Whenever we talk of spine surgery, like for degenerative spine, for craniovertebral junction, for Chiari malformation, for OPLL, for Hirayama disease, for disc herniation, we talk of one thing, compression. And the treatment is decompression. That is, we are used to listening and talking about this all our spine surgery life. So I wish to take you beyond this word decompression. I want to take you to another world of spine surgery. I want to introduce to you an absolutely, which I have talked already. I have talked on various occasions on this subject. And I want to repeat it. I want to repeat it because it is so different. I want to repeat it because it is so novel. And I want to repeat it because it is an absolute game changer for the patient. The concept is compression is not the issue in spine surgery. Compression is never primary. Compression is always secondary to segmental spinal instability. Compression is always a naturally protective phenomenon, and compression is always reversible. So many things I have talked about, that compression, like osteophytic compression, ligamentum flavum herniation compression, and so any other compression in spine is always secondary, and it indicates unstable spine. It is protective and it is reversible. It indicates unstable spine and it indicates that stabilization is necessary. And my concept is that decompression is never the treatment. So it is completely different concept. But I have to tell you, my dear friends, I am absolutely positive that this is the future of spine surgery. So please listen to this. You will have questions and I will certainly like to answer them. So the human body is different. All our muscles, we are focused on the stand, on two legs, straight. All our muscles are focused on the facets. All our muscles, there are very few muscles in front of the spine, like in the body and around the disc, there are hardly any muscles. All our muscles are behind, in the nape of the neck, in the back of our spine. And all the muscles take part in making the body straight and supine and standing and sitting and dancing. So all these muscles have one major role in making the human body straight. All these muscles attack the facets, means they are focused on the facets. Facets are the pulley. Disc, around the disc, there is no muscle. If you read my articles on this subject, I have said that disc is like air in the car tire, air. Without the air in your car cannot move. But the movement of the car is done by the petrol and by the motor. Petrol and motor are the muscles, and the pulley is the fulcrum, is the facets. So this is the basis. When the when the muscles become weak, there is instability at the facets. If there is instability of the facets, from there starts the problem. So this is the only animal that resembles a human body is chimpanzee, and chimpanzee also does not have a straight spine. It is bent. And when the chimpanzee runs fast, it uses its hands, so it becomes four-legged. A small little baby is like a chimpanzee. And then the chimpanzee becomes a human being when first he starts holding the head and then and he starts walking and sitting and then becomes straight. These muscles become strong and active. So human body, the center of the fulcrum is like this along the spine. And the fulcrum of a chimpanzee is in the middle, and the four legs of the chimpanzee hold the body. So human spine, the muscles are the critical issue. Facets are the critical issue. So I want to introduce to you, my dear friends, a concept, a novel concept, that when these muscles become weak, there is a phenomena called vertical facetal instability. The facets slip, or there is listhesis at the facets. And this listhesis, if you see your grandfather, he's shorter than you, because there is a listhesis of all the facets. There is listhesis at the facet. There is instability at the facets. This instability at the facets, I call it telescoping of the spine, telescoping. You cannot identify this instability on dynamic imaging. You do flexion, extension, you cannot identify this instability. So before I go to instability and spinal spondylotic disease, I will just briefly summarize my last lecture on craniovertebral junction, in which I said that decompression is not the issue. Few slides I will show you about my craniovertebral junction. In subaxial spine, there is vertical instability. In craniovertebral junction, because the facets are flat and round, there is circumferential instability or central or axial instability. Chronic, when there is a chronic instability, it results in secondary manifestations like Chiari, Syrinx, degenerative spine, OPLL, Hirayama disease. So when there is a chronic instability, there is an issue of central or axial instability. I would like to explain to you what I mean. So I have shown you this slide in my last lecture, like basilar invagination, atlantoaxial instability. The facet of C1 is in front of the facet of C2. This is type 1 listhesis. Nobody had ever recognized facets in basilar invagination. Compression is the issue, but instability, listhesis of the facet, listhesis is the problem. Instability is the issue. For this, no decompression should be done. Stabilization is the trick. For this kind of basilar invagination, the whole world will do foramen magnum decompression or all other kinds of things. I have said in my earlier lecture that there may not be any compression here, but there is listhesis. C1 is behind C2. This is type 2 atlantoaxial instability. This is unstable spine. Decompression, foramen magnum decompression, or any kind of decompression is negative. Stabilization is the treatment. So this is type 1, this is type 2, facet behind. Type 3 is when the facets are in alignment, but presence of Chiari, presence of serines, presence of assimilation of atlas are all clear indicators of unstable atlantoaxial joint, and stabilization is the treatment. Decompression, in my view, is completely a negative form of treatment for all kinds of Chiari malformation. Of course, I'm not talking about tumor and Chiari or craniostenosis and Chiari and hydrocephal. I'm not talking of those things. I'm talking of regular Chiari and serines. So when there is chronic instability, there are several naturally reparative phenomena or adaptive phenomena. Like Chiari is secondary, syringomalia is secondary, basilar invagination is secondary, Klippel file is secondary, platybasia is secondary, bifid C1 is secondary, os odontoideum is secondary, short neck, short head, torticollis is secondary. So all these things which are mentioned here, which are considered today in the neurosurgical or spinal surgical literature as pathological, are all secondary to chronic atlantoaxial instability, and for all, the treatment is atlantoaxial stabilization. When Chiari is present alone, when Chiari is with serines, or serines is present alone, or serines is present with basilar invagination, or any of these problems are present discretely or in cohort or together, when basilar with Chiari or Chiari with C2-3 fusion or C2-3 fusion alone. If there is C2-3 fusion alone, it is atlantoaxial instability. When there is bifid of C1, it is atlantoaxial instability. So chronic atlantoaxial instability is the issue. So we should understand acute instability is different. Chronic instability, there are several secondary things which appear, which look like pathological, but they are not pathological. They indicate instability and they indicate the need for stabilization. So basilar invagination, Chiari malformation, syringomalia are all secondary to atlantoaxial instability and no decompression. Decompression in an unstable atlantoaxial joint is a negative phenomenon. So when you see Chiari, look at the facets. There is facetal malalignment. In this case, believe me or not, if you do decompression, you harm the person. You do fixation, you create a magical solution or a result. When there is Chiari and serines, even if the facets are not markedly malaligned, even if there is no compression by the odontoid process, do atlantoaxial fixation and you get a magic. So what we have to do is learn the art of atlantoaxial stabilization. So when there is Chiari, when there is serines, when there is assimilation of atlas, even there is no facetal malalignment, no atlantodental interval disturbance, it is atlantoaxial stabilization is the treatment. So over the years, I have got more than 600 cases of Chiari and serines where I have not touched the serines, where I have not done any decompression. I have done fixation. And believe me, my friends, I'm talking to my dear Brazilian friends where these problems are very much where I have seen a lot of basilar invagination and syringomalia. My answer to this question is one, do not do foramen magnum decompression. Do not open the dura. Do not manipulate the tonsils. Atlantoaxial instability is the issue and stabilization is the treatment. Syringomalia will reduce in 100% of cases if you do investigation after 6 months or 1 year. It will reduce in about 30 to 40% if you do after 15 days. But whether 15 days or 1 year or 2 years, syringomalia is not the issue. Patient will recover from majority of symptoms in a remarkable and magical way in the evening of operation. Most important is learn the art of opening the joint, learn the art of putting bone in the C1, C2 facet, and do solid C1, C2 fixation. So this was my paper about few years ago where I discussed, and I want you to read this paper. I want you to please read this paper because it will answer several questions of yours. All of you have been doing decompressions. I was doing decompression. You please read this article. I believe complete revolution in spine surgery. Chiari is secondary, it is protective. Syringe is secondary, it is protective. It is not malformation, it is formation. I labeled it as natural airbag. Syringomyelia is helpful, not harmful. It indicates atlantoaxial instability. It indicates the need for atlantoaxial, not syringostomy. Do not do syringosubarachnoid shunt ever. Idiopathic syringe, when syringe is present with basilar invalidation, without basilar invalidation, with Chiari, without Chiari, with a clipple file, with assimilation, or with any kind of association, it indicates C1, C2 instability, and C1, C2 stabilization is the treatment. You please read this article of mine where I've shown all my 9 cases. About 5 years ago, this article was published. Now I have got several more cases with preoperative and postoperative imaging in idiopathic syringe. Short neck, torticollis are all secondary. They are all protected. They are protected. They indicate unstable atlantoaxial joint. They indicate the need for stabilization. And you can introduce beautiful smile on these patients. Cervical fusions. Cervical fusions don't do any osteotomies and things like that. Cervical fusions are protective. And cervical fusions like this do not do any kind of decompression. Even when there is no compression at the atlantoaxial joint, it indicates unstable atlantoaxial joint, and you do atlantoaxial stabilization, and you get a magic in the result. Even subaxial spine, even dorsal kyphoscoliosis can be related to central atlantoaxial instability as a protective phenomenon. In this kind of dorsal kyphoscoliosis, you will say that breathing is problem due to kyphoscoliosis. You will say limbs are weak because of the kyphoscoliosis. No, it is not due to kyphoscoliosis. It is due to Chiari malformation, or it is due to basilar invalidation, or due to central or axial instability. You do stabilization and you see the magic, a magic which you have never done, never seen by doing multi-segmental stabilization. So this is a new concept. In this age group, in this adolescent age group, you see the kyphoscoliosis. This is almost 2 months after surgery. You see the straight spine, not just the straight spine. The entire human being is new, and that is the magic in this treatment. Now I go to today's subject, anterior cervical spine fixation. Anterior approaches to multi-level spondylosis I have been doing for a long time. I wrote this article in Schuit and Smidek book, which is one, as you all know, one of the major books in neurosurgery. So anterior surgery I was doing for a long time, and this kind of anterior decompressions and anterior fixation I have been doing for a long time. And I was doing, various kinds of patients. Now I take you to another chapter. Carefully see this chapter. Degeneration of craniovertebral junction, nobody talks. When we talk of degenerative spine, we talk of C5, C6, C6, 7, C4, 5, sometimes C3, 4, never C1, C2. Atlantoaxial joint is the most mobile joint of the body. Atlantoaxial degeneration is the most common spinal degeneration which is neglected and which is not treated. So in 2010, for the first time, we wrote that instability, craniovertebral instability, is the issue in degenerative osteoarthritis of atlantoaxial joint. My dear friends, please, I want you to see this slide very carefully. reduction in the facetal articulation space, this joint space reduction, buckling of this ligament, osteophyte formation. These are not primary processes. They are due to chronic atlantoaxial instability. Chronic, not acute. Chronic instability. They indicate instability. They are secondary. They are naturally protective and adaptive, and they are reversible. Osteophytes in the apical ligament, osteophytes behind the bone, osteophytes in front of the bone are not primary processes. They indicate chronic atlantoaxial instability. They indicate an unstable atlantoaxial joint, and they indicate the need for atlantoaxial stabilization. Decompression is a negative treatment. If you do only decompression in this case, you have actually harmed. You might get a quadriplegic patient, in my view. Instability is the issue. Removal of bone and unstable spine is a negative phenomenon. Stabilization is the treatment. Retroodontoid pseudotumor. The whole world was doing transoral surgery or lateral surgery or this kind of surgery to decompress. For the first time in the literature, we said that retroodontoid pseudotumor is like an osteophyte, subaxial osteophyte. It indicates instability at the atlantoaxial joint. It indicates the need for atlantoaxial stabilization. Any kind of decompression from front or from behind is a negative form of treatment. You will say there is so big compression, why not do decompression and all? No, decompression is not the treatment. This realign, and stabilize. So retroodontoid pseudotumor is unstable atlantoaxial joint, and stabilization is the treatment. Retroodontoid cyst, in the presence of assimilation of atlas, in presence of atlantoaxial instability, you remove the cyst, you will harm the person. This indicates unstable spine. This indicates a reaction to unstable spine. You stabilize, this cyst will disappear, and there is no need to touch the cyst. Cyst removal is very easy. You puncture the cyst and cyst is gone, but it is not necessary. So retroodont, you see there is a bone defect and there is a retro C2 body in cases of os-odontoideum, a very common phenomena. I have reported a dynamic phenomena, like you do flexion, this retroodontoid thing goes inside and then comes out. There is a dynamic phenomena. Unstable spine, stabilization is the treatment, decompression is negative. So I wish, my dear friends, you read my article in World Neurosurgery, where I have given my experience with 63 cases of retroodontoid pseudotumor and things like this. Retroodontoid pannus. This pannus in rheumatoid arthritis is due to vertical instability. This is due to buckling. There is no need to remove. The whole world was removing pannus by transoral surgery. It is not necessary. This indicates unstable spine. This indicates the need for stabilization, and there is no need to touch it. Now I go to subaxial spine. C1, C2 instability, I have discussed in my last lecture, is the cause of basilar invagination, listhesis at C1, C2. Listhesis of the subaxial spine is never discussed in the literature. Listhesis of the subaxial spine is due to muscle weakness, due to muscle abuse, due to muscle disuse, due to injury to the muscles. And these muscle weakness leads to listhesis at the facets, instability at the facets, osteophytes at the facets, never recognized in the history of spine surgery. Facetal instability is the issue in degenerative spine surgery. Carefully look at these slides, my dear friends, carefully. Reduction in the intervertebral disc space, reduction. Bulging of this disc, bulging of this disc. Osteophyte formation. Bulging of these discs are not primary processes. They are due to vertical spinal instability. You cannot see that instability on dynamic imaging. You will not see any instability on dynamic imaging. You will not see any listhesis of the vertebral body, maybe a little bit here and there. But what you see is osteophytes, reduction in the intervertebral space, bulging of this. They indicate unstable spine. They indicate these are protective processes. Osteophytes are protective natural processes. They are not pathological. The whole world of spine is focused on removing the osteophytes and the disc. It is negative process. They indicate unstable facetal joints and they indicate the need for stabilization. So in my history, in my own personal history, as I mentioned, I was very good in anterior surgery. I was very good in, I described oblique corpectomy. I described tricortical screws and various kinds of issues in degenerative spine. But what I want to show you is 15 years ago, I described that this kind of osteophyte, this kind of compression, you introduce intra-articular spaces, you do distraction. And there can be immediate postoperative reversal. You do distraction of facets. So at that time, 15 years ago, I was regularly doing this operation by distraction of facet and intra-articular spaces. You see this bulging ligamentum flavum, bulging disc. So as soon as I did this, the alignment change, the facet change, and most importantly, remarkable clinical improvement in patients. So this was my concept 15 years ago, not today. I will tell you what I do today. So this was my article in Journal of Neurosurgery, where I said that facetal distraction can be used for single and multi-level cervical spondylotic myelopathy. This was my article. Same concept I used for degenerative lumbar canal stenosis or lumbar canal stenosis. The whole world means stenosis means decompression. I'm saying decompression is not the treatment. They are multi-segmental unstable spine. I wish, my dear friends, you please read my articles, many articles on this subject. These kind of bulging discs are indicators of unstable spine. I introduced intra-articular spacers and I published this about 15 years ago. My experience with multi-segmental intra-articular spacers, this was 15 years ago. And I did many cases at that time. So this was my paper. So essentially, the whole world of spine surgery, the basis of treatment is decompression is the treatment, compression and deformation is the problem. So decompression has been the treatment. So initially I did facetal distraction, which was an indirect method of decompression. But then I realized that it is indirect decompression is also not necessary. I realized that only fixation for cervical spondylosis is the treatment. No decompression, no direct or indirect, no facetal distraction, no spaces. And about a few years ago, I wrote my experience with 215 cases. The title is Muscle Weakness Related Spinal Instability is the Cause of Spinal Degeneration, and Spinal Stabilization is the treatment, no decompression. So this is a remarkably different concept of treatment of spinal degeneration. So this is a multi-segmental spinal degeneration. Just give me 1 minute, please. Just give me one. I want you to relax in the meantime. Just
Alguém poderia comentar um pouco até agora a aula dele? Anyone has any comments until now?
Okay, I'm back. If you have, I
Oh, back.
agree that if there are some comments till now, I will like to listen. But I will suggest that let me finish and then we can have
Okay,
comments.
okay, no problem. Okay.
So the issue is, you see this multi-segmental degeneration and severe compression of the cord. You will agree that the whole world will do anterior decompression. You will agree that some people, particularly in Japan, they do laminoplasty for this. But what I have done, if you realize that I have not done any decompression, I have done only fixation of the facet. I use transarticular fixation technique, transarticular. And you see, after 18 months of surgery, all these changes have completely disappeared. And you have to believe me, you see, my patients are talking in Indian language, so I cannot show you too many patients. But I can tell you that magic is the clinical result in the immediate postoperative period. Magic. And I am sure Marcos, when he was here in India, I showed him some magical results. And I have done several live surgical workshops. Even in Brazil, I have done one live surgery in Rio with in the National Orthopedic Department center in Rio, where I did 2 or 3 cases twice. I did 2 times where I did only fixation, and magic was the result, which was seen by many Brazilian neurosurgeons. Now you see this multi-segmental spinal compression, multi-segmental ligamentum flavum buckling. The whole world will do decompression. I was doing decompression, laminoplasty or corpectomy or discoidectomy or this like. I have not done any decompression. I have done transarticular Camille's technique. I do 5-level fixation in 20 minutes or 30 minutes. Very quick, very easy, very safe, very strong. And you see the whole thing has reversed in a magical fashion, which you have never seen. You know, you can never imagine that you have not done any decompression. So my concept is all this compression are related to instability, and they reverse when the spine becomes stable. So we should look at degenerative cervical myelopathy with different eyes, with different vision. Instability is the cause of symptoms and stabilization is the treatment. That is the concept. It is also, read this sentence, not neural deformation or compression, but instability is the cause of symptoms. So this is, now if you ask me what is the main issue in degenerative spine, main issue in degenerative spine is to identify which segments are unstable and which segments need stabilization. I hope you understand. I will repeat that. We have to identify which segments are unstable and which segments need stabilization. So what are the indicators of spinal instability in degenerative spine? For instance, this patient, there are 2 levels of compression of osteophytes and ligamentous flavor of posterior longitudinal ligament buckling. But I have done 4-level fixation. And after 16 months of surgery, you see the whole thing has neutralized. This complex has gone. And you have to only believe me that magic is the clinical result. Patient post-operatively will be relieved of beautifully relieved of his symptoms. Another patient, you see multi-segmental compression. This is at 3, 4, 4, 5, 5, 6. But I have done 2, 3, 3, 4, 4, 5 fixation, no decompression. You see, after a few months of surgery, the whole thing has reversed. There is no decompression, only stabilization is the treatment. This is another case. You see here, compression, compression, and this is after a few months of surgery. I have done only fixation, no decompression. Another beautiful thing in degenerative spine, which we do not know, we do not know that atlantoaxial instability. Atlantoaxial instability can be frequently associated with subaxial spinal instability. Like this is subaxial spinal instability. There is no compression at the C1, C2 articulation. But you see the facets. You need to do C1, C2 fixation in addition to subaxial fixation. But now I have changed my technique of C1, C2 fixation in these kind of situations. I do modified technique of C1, C2 fixation, which you must read in my paper, where I have said that you can do C2, 3 fixation, remove the muscles of the spinous process of C2, and then you do just fixation. C2, 3 fixation, subaxial fixation, transarticular Camille's technique of fixation. As I have mentioned, I do 5-level, 4-level fixation in 15 or 20 minutes. You have to know how to do it. Then you have to cut the muscles you have to make. I use spinous process bifid bones and place it over the implant to do bony fusion. You see this severe compression. This is after a few months of surgery, no decompression, and believe me, magic is the result. Another very beautiful scenario in India, and I am sure also in Brazil, some patients come on a wheelchair. Some patients come on a trolley. Severe myelopathy. And when there is severe myelopathy, more often than not, atlantoaxial instability is associated. You see, there is not much compression, but patient is on a wheelchair. You please read this article of mine where we have shown that if 50 patients had come on a wheelchair, almost all of them are now walking by themselves. So it's dramatic clinical result, no decompression, only stabilization. When there is severe myelopathy, atlantoaxial instability is very frequently present. You stabilize atlantoaxial joint and subaxial joint, and stabilization is the treatment. As I mentioned to you, I am now using alternative C1. I don't include direct C1 in my fixation construct. This is during COVID times I had done. She had come on a wheelchair, and now this young lady is completely, believe me, completely normal lady, and I have done fixation like Camille's technique. This is another. So I have now got several hundred patients where I have not done any kind of decompression. And I have to tell you that I invite you in August. I give you this information. Marcos, you please give this information to all the Brazilian friends. In August, first week, I am doing live surgical and big spinal surgery conference. I wish that all of you come and enjoy this live surgical forum for 5 days. This workshop will be there. This is another case of multisegmental spinal degeneration with various issues. So there are, in spinal degeneration, one is osteophyte. When osteophyte is present, it indicates unstable spine. Symptoms, clinical presentation, pain in the arm, radiating pain, numbness over the dermatome, that indicates the level. Also, when you expose, you can manually manipulate the spinous process and identify which segments are unstable and stabilize those segments. And then you have to stabilize above and below. You see here, there are 3, 4, it starts. Why I have done C2, why I have included C6, 7. You please read my articles on this subject. Lumbar canal stenosis. You see, this is in Neurosurgical Focus. You all know this journal, one of the leading journals of neurosurgery. And you see the title, Lumbar Canal Stenosis, Analyzing the Role of Stabilization and Futility of Decompression. No decompression, only stabilization. And we have got several patients and most astounding results that you can never imagine by decompression. So we have said in one of my articles that we should not use the word stenosis. Stenosis, when you use the word stenosis, you need to decompress. It is not stenosis. It is unstable spine. This kind of disc bulges, this stenosed canal is secondary phenomena. It indicates unstable spine. It indicates instability at the level of facets. You do Camille's technique, 4 level, 5 level in 20 minutes or half an hour, and you see the magic clinical results. This bulging is not primary. This bulging is secondary to instability at the facet. You cannot see this instability on dynamic imaging. Sometimes you see some kind of listhesis here, some kind of destruction here, some kind of osteophyte here. Sometimes the joints are widely open. So all those things can be seen. But if they are seen or if they are not seen, they indicate instability. Lumbar canal stenosis needs one treatment, and that is stabilization. Decompression, the whole world has been doing for a long time, should not be done. It is a negative form of treatment. So we have done several, this kind of huge disc herniation or disc bulge, no need for decompression. Stabilization is the treatment. When decompression fails, I have written this article, then you can come and do fixation. So these are the multiple cases where I've done trans-articular fixation, which is very easy technique. Facets are the strongest part of the spinal vertebra, much stronger than vertebral body, much stronger than pedicle. Facets, if you can do such fixation, it is the strongest. I introduce sometimes 2 screws at each facet. Sometimes I introduce 3 screws at each facet. These are small screws. So how the young lumbar canal stenosis differs from old this is another thing that you can read in my article. So the question is, the whole world is focused on removal of osteophytes. Is it necessary? My question to you is it necessary? And my answer to you is, it is not necessary. It indicates instability. It indicates the need for stabilization, and it indicates that stabilization should be done. So this article of mine in World Neurosurgery, I wish that you please read it. I have mentioned as to what happens to the osteophytes after you have done only fixation. So these are osteophytes you have done. These are no instability here. Instability is seen here. Stabilization is done. And this is after a few months. This shadow in the spinal cord remains. And I'm evaluating the nature and significance of this shadow. Deformity of the spine. When there is this kind of kyphotic deformity, this kind of smooth deformity, do not do any kind of decompression. Deformity indicates instability. Instability is primary, deformity is secondary. So in this case, there is atlantoaxial instability. I have done atlantoaxial stabilization. In this case, there is subaxial instability. This C, you have to identify which segments are unstable and you do stabilization. In this case, there is central or axial atlantoaxial instability. There is no need for anterior or posterior decompression. You do stabilization, and you have to, believe me, you have to see this magic of clinical outcome. Now I go to another little bit, rather you will be surprised or you will be a little bit confused as to what I'm saying, but please listen to what I'm saying. I'm not saying you have to follow this, you have to believe in this. I'm not saying, but you listen to what I'm saying. Prolapsed disc. When a person lifts heavy weights, he injures his spine, he becomes unstable, the disc prolapses. You put a lumbar belt, you put a cervical collar, you do not move the neck, there is no pain. But when you do little bit movement, there is pain. There is weakness of the hands, there is tingling of the hands. Instability is the issue and stabilization is the treatment. There is no need to remove the disc. So this kind of disc herniation in cervical spine, all of us in the literature will first give collar for a period of 3 weeks and say, okay, collar relieves pain and relieves symptoms, then we do not need to surgery. The whole world says. So in 3 weeks or 4 weeks, if the ligament stabilizes, if there is stabilization, the disc disappears. But if you do this stabilization without any disc resection, this disc will disappear in 6 weeks or 8 weeks, and the patient will improve in the immediate postoperative period. There is no need to remove the disc. So this is a dramatically difficult to understand concept because the whole world in every corner of Rio and every corner of Bombay or every corner of New Delhi, they are doing discectomies by endoscope, by microdiscectomy. I am saying, and I am saying on the basis of my 15-year experience, that this resection, this herniation is an indicator of unstable spine. Stabilization, facetal fixation, arthrodesis is the treatment of cervical radiculopathy. This article was published in World Neurosurgery. Please read this article. Controversial for you, not for me. I know there will be several questions that you will ask me. You please ask me questions, but listen to this concept. Similar is the issue in lumbar disc herniation. Do only stabilize, only fixation. The disc will disappear in no time, in 6 weeks. Identify which segments are unstable. This is one segmental disc herniation. I have done 2 segment stabilization. This disc will disappear in 6 weeks. Lumbar scoliosis. This lumbar scoliosis is not a primary phenomenon. It is secondary to multi-segmental spinal instability. Identify which segments are unstable. You stabilize, the patients will improve in all symptoms in the immediate post-operative period. Do not do any kind of decompression from lateral, from front, from behind. It is not necessary. And all these articles are published in the literature. Now I go to my last chapter, my dear friend. I don't want to talk of Hirayama disease, which is also only a manifestation of only instability, and only fixation is the treatment in Hirayama disease, not decompression of any kind. I want to go to my last chapter, and that is OPLL, or ossification of posterior longitudinal ligament. I'm not sure how much you get in Brazil, but in Asian countries, it is quite common and quite rampant. It is one of the most dangerous disease for a spine surgeon. But I can tell you today, if a person with OPLL comes to me, I become very happy. You will ask me why you become happy? Because I have got an opportunity to give him a new life. So in few years ago, I published this only stabilization is the treatment for OPLL. And about few years ago, I wrote my experience with 52 cases where only spinal fixation was the treatment for OPLL, no decompression. So this kind of OPLL, you know, and those who are doing spine surgery know that any kind of anterior decompression is not easy. To remove OPLL is not easy. To do posterior decompression is not a recognized form of treatment. You do only this transarticular fixation. Don't do any midline decompression, and you see the magic. The most critical thing that you have to understand and identify is which segments are unstable. You see, in this patient, I clearly see this segment unstable. I clearly see this segment unstable. I clearly see C1, C2 unstable. C1, C2 should always be included in the stabilization construct in OPLL. Atlantoaxial instability is very common cause of OPLL and must be included. So when there is high OPLL, of course, you have to do C1, C2 fixation. But I don't do this kind of fixation now. I do an alternative C2-3 fixation. You please read my article on this subject, and transarticular fixation. Multiple OPLL, and you do fixation, and you see a beautiful clinical outcome. This kind of OPLL are dangerous. You can create quadriplegia if you do unnecessary decompression from front or from behind. You do this safe surgery, and you see a beautiful revolution. Atlantoaxial and subaxial cervical fixation can produce a revolution in the treatment of OPLL. So can decompressive laminectomy, anterior corpectomy, anterior discoidectomy become historical in the treatment of degeneration of spine? I'm saying yes. Is the treatment for cervical spondylotic myelopathy and OPLL similar? Is the problem similar? I am saying yes. I wish that you please read my articles on this subject. So, my dear friends, my concept is clear, and my concept is definite. And my concept, I believe, that is the future of spine surgery. Compression is never primary. Decompression is never the treatment. So thank you, my dear friends, and I am waiting to hear many questions from you. And I know that there will be several arguments, several discussions, several criticisms, but please don't be too excited about it. Please read my papers and you will get more answers. And I'm waiting for questions from you. Please go ahead.
Okay. Thank you, Professor, for this great lecture. Many thoughts and for us to make reflections about your theory. Thank you. Now we have introduced Dr. Luis Junior, coming from the Northeast Brazilian Society of Neurosurgery. Say hello from the professor and welcome.
Thank you, Professor Goel, and our friends from Brazil. Today, as you told in the beginning, is the National Neurosurgeon Day, a day to celebrate our lives, the challenges that all of us who dedicate ourselves to this mission, bringing joy, hope, and comfort for our patients, their family. And we need dedication, persistence, resilience, balance, and always evolving is our daily routine. And we are doing this today, knowing these new concepts of Professor Goel, to share our expertise and discuss some topics. Thank you very much on behalf of Brazilian Neurosurgical Society. Thank you very much.
Thank you, and I invite the whole society. Just now, my friend from China has written on this in the chat box about my conference in August. I'm doing a live surgery conference in August on all these concepts of craniovertebral junction and degenerative spine and OPLL for 6 days. And I wish that you please join me, and I will be happy to have you as my guest in Mumbai in August.
Now, Dr. Fabio Santana has some cases to show us. Fabio?
Okay. Can you share my...
Yes. Fábio, desliga o outro som porque tá dando eco.
Okay.
Pode fazer.
Dá?
Yeah, you want to put it on presentation mode? It's not on presentation mode. At the bottom, one of the icons at the bottom right. Do you see those icons?
Tá tudo bem aí, Fábio?
Tá.
Pode começar.
Posso começar?
Uhum.
Tá a tela toda ocupada?
Tá com eco ainda, viu? Ok, pode ir.
About reproducibility of Goel's technique in craniovertebral disease. No, I was no. There is an echo. There?
There is some echo. I think two what do you think?
Computers.
Two computers are working at the same time. If you can stop one.
Okay. Vou usar isso.
Yes, now it's okay.
Oh. Tá desligado, é no meio.
Ok, tá bom, Fábio, pode ir. Deu certo.
Tá ok?
Tá, vá, pode ir. Pode ir. Fábio,
Tô?
pode ir.
Não tá dando aqui. É melhor pedir a aula do Ives antes, eu vou em seguida só mostrar alguns casos.
Okay. Denner, você pode falar agora? Here we have Denner. Can you give your opinion about the lecture of the professor?
Hello,
Hello, welcome.
thank you, you for the invitation. I would like to congratulate you, Dr. Marcos Wagner, for the initiative, this conference, né? And also Dr. Goel for sharing his experience with us, né? I want to express that the concept of instability has a determining factor in many craniocervical diseases is very clear to me, né? In fact, my doctoral PhD in 2015, under the guidance of the Dr. Ricardo Botelho, né, was precisely about the instability of these patients, né? We publication the papers that the assimilation of the arc anterior is the primary factors of the instabilizations, né? And it's in 2015, né? And I would like to ask about your approach to a specific subgroup of patients, those patients with symptomatic Chiari malformation and without syringomyelia and without basilar invagination. What's your personal approach of these patients? When do you recommend surgery? Consider the fixation is a major surgery with added risks. When do you believe the surgery has a plausible risk-benefit rate to recommend for patients do not have syringomyelia or basilar invagination, and only a simple Chiari malformation?
See, one thing I'll tell you, that Chiari is never simple. Is a very major issue. Basilar invagination is not simple. Assimilation of atlas is not simple. It indicates atlantoaxial instability. It indicates chronic atlantoaxial instability. Chronic for a long time, for 5 years, for 10 years, for 20 years. The person may not have any limb problem, may not be having any problem in the hands or legs, but there will be pain in the neck. Pain in the neck is a constant phenomenon. And if the pain is little bit more severe, then you are, of course, if there are no symptoms, zero symptoms, then you might just like to observe. But in most of these cases, there are symptoms. It is a chronic, relentlessly progressive symptom. They start with pain in the neck, then they start getting pain, tingling in the hands, then weakness in the fingers, then stiffness in the legs, then difficulty in walking, then sleep apneas. Young children get sleep apneas, then difficulty in talking, then difficulty in breathing, then breathlessness, and they have a very nasty, long-standing, worsening scenario. So these are not ordinary, these are not simple. You can observe them, but they will worsen. If you see a Chiari, it will worsen. If you see a syringe, it will worsen in next 5 years, in next 10 years. Instability is the issue. You stabilize as early as possible. The bottom line is you should know how to stabilize. You should be confident in that step. Means every operation has a potential problem. You can have a complication. But if you stabilize properly, you can get rid of this problem for life. I think it needs stabilization. Unless the person has zero symptom, no pain, nothing, then is all right.
Okay. Another question, Dr. Goel. In cases with cervical myelopathy and lumbar canal stenosis, né, does fixation with interfacet bone grafting not lead a kyphosis and saginal imbalances in case of the patient with a little lordosis?
No, it is not. When I used to introduce intra-articular spacers, 15 years ago, I used intra-articular spacers. For the first time, we described spacers in the year 2011. It was published as cover page of Journal of Neurosurgery. So when I distracted and multi-segmental distraction, there were some people who said that this kind of distraction may be kyphogenic. It produces kyphosis. I did several cases at that time. I wrote one article as to what multi-segmental distraction, how the alignment changes on distraction. But now I don't do distraction, I don't introduce articular spacers. I just do transarticular spacers, transarticular screws, and that's it. So there is no question of doing any malalignment. I do under traction. When I do this operation, I do under traction. And many a times I open the joint and denude the cartilage, but that is the basis is only fixation, no decompression.
Fábio, tudo certo?
Ready? Ready?
Ready to go.
Can you share my screen, please?
Yes, you can. All right.
Very good.
Okay, this a reproduction of Goel's technique in my experience in Brazil, Belo Horizonte, to craniocervical junction. This is my region, Minas Gerais, near from Rio de Janeiro and São Paulo. So definition is a technique to fix it, fusion, C0 or C1, C2, but C1, C2 distraction with use of C1, C2 intersomatic spaces, cages or bone. This is next presentation of Dr. Goel in Brazil, in Belo Horizonte, sorry, Porto Alegre, in Brazilian society meeting. This is your papers, books, and editor of the Journal of Craniovertebral Junction Spine. Some consideration of surgery, craniocervical junction. This is a serious disease, mortality about 2 or 12%, high complication rates, requires a great technique demand and multidisciplinary team. This is about anatomy of C1, C2 facets. There is no problem with the venous plexus and segment of V3 of the vertebral artery. There is a small, in some cases, small branch about V2 segment. Some anatomy, as in some cases, the pica emerges of V3 segments. There's some care about this. This is anatomy that I use for fixation C1, C2. There is along the anatomy and an anatomy for pedicle of C2. About this anatomy, it's possible to insert of cervical cage for ACDF. This is antique, old cages that Dr. Goel used. In a technique, you have to cut the root of C2. At the present, I use the cervical cage to put in the C1, C2 facets. There is not in Brazil, this cages for use in C1, C2 spacer. This is a colleague from China. At the present, I use this lumbar cage for 6 millimeter wide, and the distance 22 millimeter. Is it possible to put these cages in C1, C2? This is the line. I use the McRae's line to detection and diagnostic of basilar invagination. The past, I use traction, but at the moment, I use the Mayfield clamp surgical technique. This is a case of invasive invagination, 59 years old. You see the facets. Is it possible to insert a cage or bone? I use all CT scan, angio CT scan, and measure the pedicle of C2. There is a C2 assimilation, and I prefer, this is a picture of the surgery, expose the root of C2, occipital, insert the cage. Can you see in cage, insert the C1, C2 spacer. I use this tool to remove bone graft on iliac crest to avoid pseudoarthrosis. Some rasp to C1, C2 facets. This is a set about this tools. You see the C0 to C2 translaminar approach. This is results, good results. Only fixation. You see the cage insert in the C1, C1 space. In this case, I prefer to use translaminar screws. You see the CT scan the C1, C2, Goel's technique in some cases. I use your technique, only decompression. This is 6 months later. About post-operative time, the syrinx is remodeling. This is a complete fusion, C1, C2. Instability, C1, C2 in rheumatoid arthritis. I use this technique. The position, the screws, the cages, os-odontoid or pseudoarthrosis or C2 fracture. I use this technique, cages insert and screws, C1 and C2. This is a result of fusion, totally fusion, and good results. Post-operative control, instability, C1, C2, invaginal invagilation with assimilation of C1. This is McRae, this is basilar invagination, the distance of the anterior arch of C1 and odontoid. MRI, the measures of C2 pedicles technique. I use C0 to C2, and basilar invagination is good result. And challenger case here, there's the revision in surgery and cerebromegaly. I use the Goel's technique. There's a total fusion, but results not good. Revision in Chiari invagination is a challenge yet. One complication, a leak, resolved with fibrin glue. There's the type of the cage do you have to insert to avoid damage to basilar artery. This is the last paper of Dr. Goel. In this paper, Dr. Goel used bone. I never used bone, only cages. In conclusion, a good technique for basilar invagination, arthritis rheumatoid, non-consolidated fracture of C2, also odontoid, short assembly, spaces guarantee a high fusion rate, disadvantage of learning curve, correct statistic in our service, 23 cases. Thank you so much.
Thank you, Fabio. Very good lecture. You are a great surgeon. Professor Atul Goel, any comments about his philosophy and what you think about it?
No, I agree. A wonderful lecture. There is no question. I will give some points. As you know, that direct fixation of C1, C2 is a difficult operation. But it is a most fantastic, if you do it, fantastic clinical results. Nowadays, you see, I described occipital screws in the year 1987. I described occipital screws. But now I don't do occipital fixation even when there is assimilation of atlas. I don't do occipital fixation. C1, C2 fixation, I do in every case. The most difficult, and I do not cut the C2 ganglion in every case. Very rarely I cut. So most important issue is to open the joint. I described intra-articular spaces in the year 2002. Means about 22, 24 years ago, I described intra-articular spaces. And those spaces of mine are patented in US in various 21 patents I have got of spacers in various countries. But I do not use spacers now very frequently, only rarely I use spacers. I open the joint, I introduce bone graft in the joint, a lot of bone graft in the joint. And then I do one in C1 and one C2 direct screw fixation. Even in the difficult cases that were shown, like the vertebral artery was so high, the pedicle was so thin, even in those cases, you can actually identify the safe spot of introducing the screw in the C2 pedicle, and you can go actually medially, you can go in some situations, if you are not able to go in the C2 superior facet, you can go in the C2 inferior facet. That is also one article I have written in World Neurosurgery. You please read it. I do not like to do laminar screws or spinous process screws. I do not like to do. I like to do direct C1, C2 pedicle screw, and this is what I like to do. But as you rightly said, it is a difficult process. There is a lot of learning curve in this surgery, but we have to learn. If this neurosurgery is difficult subject, spine surgery is difficult subject, craniovertebral junction is the most dangerous and difficult subject. But the problem is dangerous and solutions are dangerous, and we have to learn these dangers of neurosurgery in this situation. Marcos.
Thank you, Dr. Goel.
I like to see my picture in about 7, 8 years. I look much younger at that time and more hair. So it was a beautiful picture you showed me. You please come to Mumbai in August, okay? I wish that you can come to Mumbai, and I will like to show you several cases during that time.
Good. Thank you so much.
Marcos, your microphone is off.
Okay, Professor Evans, do you want to give the final remarks?
I'd like to thank you, Professor Goel, for this beautiful explanation and for opening our vision about spine surgery. I guess it's a very original concept that you have learned from you. And I'm very happy to have this opportunity to see you many times and to learn with you and to change my mind and to go after these new concepts and to learn it. Thank you very much. It was a very nice presentation. Max asked me to give a presentation about my Chiari-1 hypothesis. And I thought I told him that it might be left for another time. So I hope to see you again and share with you my anthropological concept of Chiari-1. Thank you very much.
Thank you.
Okay. Anyone more want to? John Bennett, can you invite others to speak? And
Harshad, you've been very quiet tonight.
Hi, John.
Over in Mumbai. He's in Mumbai.
Hi. Hi, John.
Hi.
Hi, Atul.
Hello.
As usual, wonderful insight of craniovertebral junction and whole spine surgery. And I 100% agree with you what you say. There is a total revolution in understanding of the spine surgery. And I admire you, as I have told you many times, you can change your own concepts. Earlier you were doing all decompression, fixations, and many have learned, including me, from you, how you do it. And now you are changing your own concept. You require guts to do that. And you have, because you have a substance to prove that this is the gold standard operation available now for C1, C2. And I'm sure people will accept it as the time grows. And you are the king for that, and no doubt about it. And another case just now shown that, yes, it does work, and wonderfully. You have shown even the Camillus technique, whether it is cervical spine, lumbar spine, thoracic spine. Wonderful, wonderful. And it is always pleasure to learn from you every time when we hear you. I must have heard you 100, 200 times, but every time I feel I'm learning for the first time. It's a great, great, great honor.
Really, thank you. And Professor, so next for us to end all of these lectures, what do you suggest for next series, next session, the last one?
I will like to show you some cases, some results of the operation. Maybe one by one, I will show you pre-operative and post-operative outcome clinical cases.
Mhm.
So I think that may be useful.
Okay, thank you.
Marcos,
So
let's
everyone-
see if Professor Arnaldo is there. Are you there, Professor Arnaldo Arruda?
Okay, one moment.
He has lots of expertise in Chiari treatment.
Oh, sure, like to
Okay.
hear from.
No,
Oh,
I
he's-
think he's not.
Is he here? Is he here?
Okay.
Let me check on him to see if he's in the
Okay.
panel.
José Arnaldo Arruda.
Is he here, Marcos?
Yes.
Okay, let's try to track him down.
Luiz,
Anthony-
você pode chamar na próxima vez e falar pouco, né?
Mhm. Okay, let's go on, John. Maybe he cannot talk to us only here. So go on, Marcos.
Okay.
Okay.
Okay, very good. I'd like to thank everyone, including Marcos, for putting this together. And of course, as they always say, the king has spoken.
Thank you very much,
Okay.
my dear John, for organizing all this. And, you know, this platform there is no question that this is a great platform. And I have the big honor in talking on this platform for so many times, maybe more than 100 times, John, on your platform.
At least.
Mhm.
And we have a link, to all your talks in the post. If they want to see the talks you've given over probably the last 5 or 6 years.
And I can tell you that through this platform, I have been able to disseminate many of my concepts very far and very wide and very deep into the world of neurosurgery and spine surgery. So thank you very much for organizing this, and my best wishes to you. And Marcos, thank you for taking me to Brazil, and I look forward to joining you in the G20 summit in your country. And during that time, let us organize a beautiful live surgical workshop where I want to show many of these things like you.
Okay.
It would be a great pleasure. Okay, Marcos?
Very
Thank
good.
you.
Okay, until the next time. Thanks, everybody.
Thank you, John.
Bye-bye.
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 Okay.